with some of this big data. And then for the second half of the talk, I'll go into a practical example with a study that I've done where we looked at some of the things Jim was just talking about with Christakis and Fowler's paper, looking at peer effects and social influence, but within a chemotherapy ward and done entirely using electronic medical records and hospital administrative data. And please feel free to stop me at any point with questions. So electronic medical records. These are the data that hospitals collect on patients that tracks their health through a variety of mechanisms. So it can include mainly the clinical charting, which is added to from the physician. So when a physician is asking a patient questions or doing blood readings, blood pressure, temperature, et cetera, when they do your ear with a little light, all those kinds of things are getting added to your electronic medical record. Also, things like the staff coming around, if you're an inpatient getting readings from the staff nurses, other people adding information to your record, and then also the patient themselves adds information to the record. When you go into a hospital, you're in a waiting room, you're filling out the little questionnaire of your health history, your family's health history, that can also get added to your electronic medical record. And part of the nice thing about the record being electronic is that it can follow you from hospital to hospital. So this is ideally something that is used to track your health as you go through the medical system in its many forms. On the other hand, hospital administrative data is data that's collected by the hospital primarily for its own internal use. So this can include things like when you're in a various hospital ward, when you're moving from hospital to hospital, where you are, what you're doing. It also includes things like the ICD-10 codes or ICD-9. So ICD is the International Classification of Diseases system, which allows any thing that is billed by hospitals to be incorporated into the hospital administrative data. And there's various codes for different types of diseases, different types of things, but they're not diagnoses. The diagnoses are part of your clinical chart and your electronic medical record, whereas these are primarily used for billing. So it helps separate out the two types of data. And a lot of this gets used for billing purposes. So that's just to sort of separate out these two things, where the data comes from, what data is available for access. These are things that you need to be sort of cognizant of as you're doing research with electronic medical records and hospital administrative data, as which type of data you have can impact the types of questions you're able to ask and things you should be aware of. So thinking about the benefits of electronic medical records and hospital administrative data. So a lot of these stem from the fact that it's sort of big data, but it's also health and hospital data. So we're all here for health and networks. So having a source of data that comprises a patient's entire history of their health status, what they've done in the hospital, has huge benefits. It also includes outcome data. So it sounds like I'll talk about it a little bit. It's sometimes difficult with network data to find outcomes and to have outcome data that relates to networks and network positions. So this being already incorporated into the electronic medical record really eases some of that process of getting outcomes. As I said, it's big data, so you have both a lot of observations, so many patients, but also many observations or variables per patient. And that combination really allows you to get at a richness and a depth with your analysis you might not be able to with only a couple hundred patients or only a few variables on each patient. It's also inexpensive from the researcher's point of view. In particular, the data is already internally housed at hospitals, and the infrastructure has already been put in place by them to both house the data and to collect additional data. So once you're able to get access to the data, the cost both in terms of time and financial resources is fairly minimal. One of the cool things, and this is something that I've only sort of recently come to appreciate, is that you can also modify them to an extent. So I don't mean going in and editing a patient's record, but editing rather the architecture of the record. So the lab I'm in now is a nudge unit, where we use behavioral economics to change some decision-making that goes on in hospitals. So one of the things you can do is you can look at vaccine rates for the flu vaccine, which are usually not as high as we'd like. One of the reasons for that is that patients are just not given the vaccine when they're in the hospital. So you can go in, and when a physician is seeing a patient and they're due for a vaccine, there'll be something that maybe notifies the physician of that, but the default typically is that the patient does not receive the vaccine. If you switch a line of code and you can switch that so that the default is that they do receive the vaccine, you can increase vaccination rates by up to 30%, which is huge just for changing that a little bit. And hospitals are actually fairly receptive to things like this because it directly affects things that the hospital cares about. It cares about vaccination rates. That's something that's reportable to a number of agencies, so that's important. It helps because they can bill that, and it helps the patient's health and the health of the population. So all of these things make the hospital fairly amenable to changes in the electronic medical record that can directly improve health. That said, there are a number of limitations of these type of data, most of them stemming from the fact that it's not in the researcher's control. Because it is the hospital owning the data, and this is true for pretty much any big data set, it's not in the researcher's control, and there's a number of issues with that that affect what you can do with it and what you can't do with it. So one thing is it often changes, particularly for hospitals, as laws, regulations change, as the hospital changes standard operating procedure, things within the electronic medical record can change without any external notification that they've done so. So this brings up a point that I'll keep trying to reiterate during the course of this talk, is that you need to be cognizant of what is going on in the context of the data. Because you haven't collected the data yourself, it's easy to take the data, throw it in an analysis, and see the results. But really being aware of the setting in which it's occurring, what's going on under the hood, really can add a layer of nuance to your data analysis. Importantly, it's also not designed for networks. So everything I'm going to be talking about is using the data for purposes and creating networks that it wasn't necessarily designed to do. So similarly to the Christakis and Fowler paper, where that wasn't designed for a network either, there are places you can go into this type of data and find places where networks very much make sense, but the data wasn't designed for that. And so coming up with the post hoc methods to find meaningful networks within this data can be challenging. And then finally, there's a point on sort of the ethics and patient identification and consent of this type of data. So in the past, a lot of the issue with patient identifiability and PII, so personally identifying information, has been that you can have single diagnoses or single variables, such as HIV/AIDS, which is highly negatively stigmatizing, or what it has been in the past. And identifying that point for a patient can be highly problematic. Whereas now, with the advent of big data, with some of these Facebook, the data breaches that have occurred recently, some of the issue now is more of the constellation of a lot of variables being able to identify patients. So it's important to think about how that could affect, even when you're doing aggregated analyses. So we're currently working on a paper where we're looking at patients who have a rare genetic condition and looking at their comorbidities over the life course. So once you divide up by their age, by their genetic condition, and by any comorbidities they have, already that is able to, even in an aggregated sense, get down to a very, very few sample sizes, or small sample sizes. So that's an issue with the identification. In terms of the consent, it's sometimes tricky, and it's not always apparent to patients when they go to a hospital that their electronic medical record can be used for research purposes. So there is sometimes an issue of figuring out how to best get the consent of patients. They've changed this a little bit in the EU, where the GDPR, which was instituted 2 years ago, mandates the ability for patients to rescind the use of their data, including in hospitals. So there's now a method set up that they can reach out and say, I would like to opt out of the system. Not a lot of people do that, but it's important to have that sort of system in place for data even like this, which isn't sort of directly collected for research, but can be used for research purposes. So that's generally the sort of strengths and limitations, but how do we actually make networks from these? What kinds of networks can we make? So we can have a hospital transfer network where you look at all the hospitals across the country and how patients move from hospital to hospital. So a patient comes into a hospital, they're there for a couple days. It might turn out that they have an issue that is not one of that hospital's specialties, so that hospital may have them transferred elsewhere where they can receive better care. This paper was looking at how that affects the spread of nosocomial infections from hospital to hospital. If you get a disease in one hospital, do you then take it on to the next one and infect people in that other hospital? You can look at comorbidities. So here's a network of various diagnoses and comorbidities that patients have. and they're connected. In this paper, it's actually not from electronic medical records, it's from a genetic ontology database, and there's an edge between them if they share a genetic cause, something that's been implicated in the literature is causing the disease. But you can also do the similar thing with electronic medical records. You can take the comorbidities within a patient and connect them in that manner. As Jim mentioned, you can also create some physician networks. So having physicians who are connected either by sharing a patient, sharing referrals, getting information from other physicians, all these can relate to physician networks. So some of the early data in the spread of innovations looked at how drug referrals passed through these physician networks, how which drug a physician may prefer was influenced by their peers and what their peers preferred. And then you can also have patient co-presence networks. So looking at which patients are in a various hospital or in a various ward or a room of a hospital, and how being around those other patients can affect you. And that's where the example I'll be talking about in a little bit is going to focus. We're going to be looking at patient-patient co-presence networks and how we can look at some peer influence effects there. But importantly, the network data don't come like, or sorry, the electronic medical record data don't come like this. They don't come as these nice packaged networks. You have to create them or infer them from the data. So we do that by using bipartite networks. So y'all have heard about this, but just to sort of go over it again, the networks that I showed, although they were all one type of node, they started off being a relationship between two types of nodes. So a bipartite network is when you have two distinct types of nodes who can have edges between the types, but not within types. So for the hospital transfer network, you would have something like the hospitals and patients. So you can have a patient 1 was only at hospital A, whereas patient 2 was at hospital A, then B, then C. And you can then collapse down to the hospital transfer network through matrix multiplication. So you've got the adjacency matrix, and for bipartite networks, it's no longer a square adjacency matrix. It's rectangular, where you have nodes of one type on your rows and nodes of the other type on your columns. And then to condense down to the one node or unimodal projection of the network, you multiply the adjacency matrix by its transpose. So when you do that, you then arrive at just the connections between one node, where a connection is present between two of the nodes, if and only if there are those two nodes share edges to a node of the other type. And in this case, let's say you're interested instead in the connections between the green nodes, as if they share connections to orange nodes. You can then instead multiply the transpose by the adjacency matrix to get the other projection. So which one you want is going to depend on your research question. So again, so all of these networks are unimodal projections from the bipartite matrix. The hospital transfer network is patients and hospitals. The comorbidities is patients and diagnoses. The physician network is physicians and patients, et cetera. So you can take all of these, and depending on your research question, condense them and collapse them down into their unipartite projection and then do analyses on them. One issue here is that because you're doing matrix multiplication and electronic medical records have tens, hundreds of thousands of observations, the matrix multiplication can take a really long time. So one nice approach to speed that up to an extent is sparse matrices. So y'all have probably seen that networks and their adjacency matrices have mostly zeros in them. That there's only a couple edges between patients, participants, what have you, relative to the number of non-edges. So you can help speed that up within the computational setting by having the computer default to a non-edge between any two nodes and only store information if there is an edge. And when it does that, it speeds up both the computation on terms of like multiplication, but also reduces the amount of memory space the matrix takes up. So if your RAM is fairly low, it can really help speed that up. Thinking about how to do this in R, there's really three main packages that I've used to really help do a lot of these analyses. And they're not specific to electronic medical records or big data, but they are helpful in a lot of these situations. So the first one is Lubridate, which allows you to do some time manipulation. So looking at intervals, one of the key points I use that within some of the work is looking at when patients are in wards and when they overlap with other patients. And you can do a lot of that manipulation very easily and quickly with Lubridate. Matrix, specifically with the capital M, is a package for sparse matrices, so it helps speed a lot of these things up. And then ICD is a package which includes all of the different ICD-10 codes and ICD-9 codes, the conversions between them, as well as their short and long names, so you can understand a lot of the information that's encoded within just the ICD. So that's an overview of the electronic medical records and hospital administrative data. Any questions at this point? Yeah.
I work in health informatics at UIC, and I'm affiliated with Heinz VA. So I noticed that I'm assuming that some of the work that you're doing is involved with VA data. And anyone, it's a known fact, anyone who's any EMR data, it is sometimes total trash.
Sorry, what?
Total trash.
Especially billing codes.
So like, yeah. So how do you, could you touch on that a little bit in terms of how you deal with like quality control and like, especially if you're trying to get more of a meta level, so I do a lot of teams research, it can be especially complicated to try to merge data sources and make sure those are all clean.
Yep, so yeah, so the question is, sometimes some of the electronic medical records can come fairly messy, and how do we deal with that? I've got a bit of a non-answer because we ended up getting, with this case, so I am planning on using VA medical record data, but haven't gotten there quite yet. The data I got for my dissertation was actually part of a consortium where they had already brought in a lot of these data sources and had already done most of the cleaning from their end, so it actually arrived to me in a relatively clean setting, which was pretty wonderful. So I don't have a ton of additional detail on that, unfortunately. But I will say, in terms of the ICD, so yeah, as I said, the ICD-10 codes are primarily for billing purposes, not for diagnoses, and they don't always perfectly align. There's some work which shows that there's a reasonable correlation, but it's definitely not 100%. So being, again, cognizant of that and trying to understand where these incorrectness might lie is important. Yeah?
Question, thank you for elaborating on that. The EMR system that you use for your dissertation, I realized that England wasn't affected by the whole high-tech act thing that happens for the US. So what was the software that was like where the data originated?
So the data. So the question is, where did the data in the UK that I got originate from? It originated from within the NHS, so National Health Service in the UK, their system, their internal data sets. Actually, what is the data or the regulation you just mentioned?
The what?
The regulation?
It's called the High-Tech Act of 2009. Obama signed into the Affordable Health Care Act that basically really sped up the adoption of electronic health records and the requirements.
Cool. I will say also, with respect to the VA, there's, I think, movement in the relatively near future to try and switch some of the electronic medical record systems. So that'll also, as I was saying, with some of the changing systems with electronic medical records, it's important to be aware of these types of things because they can affect how the data look, what they look like, et cetera. Anything else? Cool. Okay, so the example that I'm going to be talking about is looking at social influence within a hospital setting. So we know patients are not alone in a hospital. You can have wards where patients can see one another, where they can interact, with one another. They can cough on one another if they're sick, spreading infection. And this can lead to the patients affecting the health of other patients through a variety of ways. And that can include social influence. So what do I mean by social influence? As Jim was saying earlier, it's one person's behavior or ideas influencing the behavior or ideas of another person. And this can happen through a variety of mechanisms. So something that's fairly intuitive would be just sort of two people talking with one another and influencing each other's ideas through that mechanism. But you can have something a little bit less intuitive, like social facilitation, where just being around another person doing the same activity as you can improve your performance. So they've shown that cyclists, when they're around other cyclists, improve their performance irrespective of the performance of the other cyclists around them. It can be something like modeling, where you see somebody performing a task and you mimic their behavior on that task to more match them. But you can also have negative effects of some of these social influences. So you can model somebody who is performing a task sort of inefficiently and adopt some of those inefficiencies. With social facilitation, there's work that shows that if you're eating with other people, it increases the amount that you're likely to eat. So some of these can go in multiple directions. So we then wanted to ask whether we could detect social influence in the chemotherapy ward. And the electronic medical record provided a way to really ask this in a way that hadn't been accessible before. To do this in a survey setting or an ethnographical setting, it would take looking at massive numbers of patients, following them up for long periods of time, understanding who they're interacting with and how, which, especially for something that people wouldn't necessarily be convinced of right off the bat, might be difficult to secure the funding and the time for. So what we were able to do is look within a hospital and try and find a setting where the effects of social influence would be most pronounced if they were occurring. So the chemotherapy ward is a setting where patients are receiving their treatment for multiple hours at a time. They're coming there on fairly consistent schedules for up to a couple months. And the wards are sometimes, but not always, relatively open. So again, the patients can see each other, talk to each other during their chemotherapy. So this seemed like a fairly ideal setting to test this hypothesis of social influence. So the data set we used is this Infections in Oxfordshire Research Database, which, and sort of the couple, there are two major teaching hospitals in Oxfordshire and a number of community clinics. They came together to combine information from the electronic medical record and hospital administrative data to really build this data set, primarily for looking at the spread of infection within the hospitals. But we sort of realized that this was an ideal data set to look at some of this for a social influence question. So the data set we use is just a subset. It's just all 4,700 patients in an outpatient chemotherapy ward over a period of 9 years with about 44,000 spells, where a spell is a unique entry and exit of a patient into a hospital ward. So each time a patient came, received their treatment, and left for the day, that would be a single spell. And there's a little bit of demographic information. Importantly, 2/3 of the patients in the hospital or receiving chemotherapy die within 5 years. As a bit of comparison purposes, within the States, that's closer to 50% 5-year survival rates. So again, to put into context some of this data and what this means, this is a blueprint of the chemotherapy ward as it existed at the time. I probably can't read this, but there are 2 treatment rooms, treatment room 1 and 2. This one had 6 beds, and this one had 10 chairs in it. You can notice from that that they're fairly open. The only privacy measures that were within the room would be a patient could ask for a privacy curtain to be drawn, but there were no walls separating any of the patients from the other patients except for the divider between the 2 rooms. So this was important. If this chemotherapy ward had been designed in a way that each patient received their own private room, the question we were asking wouldn't have really made sense because there wouldn't be anywhere near the same potential for patient influence. So again, it's important with the context of electronic medical record data to not only look at the data itself, but understand where it's coming from and what that might mean for your research questions. So then the next step was trying to construct a network between the patients to understand who was co-present with whom. So there were a number of ways we could have gone about this quantitatively. The simplest would have just been dichotomizing sort of any co-presence versus no co-presence. But there's strong reason to believe that it's not the case that being around a patient for 1 hour would be the same as being around a patient for 100 hours. So we ended up doing 2 methods, partly for some sensitivity analyses and to see if our results were robust to different approaches. Our first approach was using the Jacquard index. So it's the number of hours 2 patients were in the hospital ward together divided by the number of hours they could have been in the ward together. And that's a fairly nice metric. It has fairly well understood properties. And you can take that and have a network therein. But what we ended up doing also was trying to understand when patients are co-present with each other more than expected by chance. So we got the idea from Dave Schaefer, who's going to be talking tomorrow, who had done a study looking at preschoolers and their interactions within the school and understanding or making a network based on whether they had interacted more often than you'd expect by chance. For preschoolers, the underlying math is fairly straightforward if you assume that they just sort of move around randomly. Whereas if you assume that, or and deviations from that are fairly straightforward. Whereas here, again, the context of the electronic medical records matters. So chemotherapy is not randomly assigned. You get fairly regimented schedules, and there can't be a whole lot of variation within them, or the schedule will be thrown off. So what we ended up doing was building an algorithm that allowed us to make small random deviations to a patient's chemotherapy schedule, see how the distribution of their overlap with other patients was affected, and then find those overlap amounts, which were then still relatively rare given that distribution. So just to give you a quick vignette about what happened, we have 5 patients here on chemotherapy. There's a ward with some chairs, and then eventually patients are going to finish chemotherapy. So at the end of every day, because it's an outpatient ward, none of the patients will be in the ward overnight. So we start, patient A moves into the ward, patient B will then go in. Patients A and B are co-present. Patient C will come in, so A, B, and C are all co-present with one another. Patient C, this was their last day on chemotherapy, and now B and D will be co-present, and then D and E will be co-present. So at the end of the day, everybody will have had some co-presence with somebody else. C is finished, and even though C was with other people in the ward, they have no edges because they weren't consistently co-present with anybody. So that's an important distinction here, that isolate in the network sense does not mean they were isolated in the ward. It just means they were not consistently co-present with anybody. On the second day, A and B will again be co-present, as well as E. So E is now done with their chemotherapy, and again, B and D will be co-present. So now A and B have been co-present twice, B and D have been co-present twice. E has been co-present with different patients on each day, and again, has no consistent co-presence. And then finally, day 3, we'll see the same pattern. A and B will be co-present, and B and D will be co-present. So each of A and B and D were co-present 3 times each, so those are going to be consistent co-presence and will draw edges between them. Importantly, notice that it is not automatically a transitive property, so A and B and D are connected, but A and D were actually never in the ward together, so there's no transitive property by definition here. So when we do that, we run this on all 4,700 patients. We arrive at the following network, which includes 2,200 of the patients. They're colored by when they started chemotherapy. So the chemotherapy, or the study ran over 9 years. Each chemotherapy regimen lasts a couple months. So we expect that the colors of patients should be connected to patients who are similarly colored, which is a nice mental sanity check. The other 2,500 patients are largely isolates, so 2,300 of the patients are consistently co-present with nobody else, and then the remaining 200 or so are consistently co-present with maybe 1 or 2 other patients, but not connected to this large component here. You can see the density is relatively low at 0.001, and the transitivity is fairly high. Every time patient A is connected to B and B is connected to C, 25% of the time, you also see the A to C connection. Okay, so that gave us our network, and now we wanted to bring in some of the influence in looking at an outcome. So I mentioned that the electronic medical record has nice access to outcomes, particularly within the UK, where the death date of a patient is recorded on a national level and added into the electronic medical record by virtue of a number of national level systems. So we had the death date through 2015 for any patient who had died within the EU. If they moved outside of the EU, we didn't catch them, but we assumed that was a fairly small number of patients. So what we did is we had an outcome of 5-year mortality following their chemotherapy, and we built a generalized estimating equation model with the following 3 network structures in it. So first, we asked, does being an isolate in the network relate to survival? So if a patient is an isolate within the network, has no consistent co-presence, does that predict their survival? Second, for those that do have some consistent co-presence, and we break down the ties they have to those alters who either survived for 5 years following their chemotherapy or did not survive for the full 5 years following their chemotherapy, does the number of those patients to whom they're connected relate to their mortality outcomes? And then finally, is there sort of a 2-step effect? So this again goes back to the Christakis and Fowler question, in that we actually use this as sort of a negative control. We did not expect for somebody that you've never really seen or overlapped with in the hospital to have a discernible effect on your outcomes. So this sort of served as, again, a bit of a sanity negative hypothesis, negative control. So our results are shown here. Just to orient you in terms of some of the numbers, our null hypothesis for this model would be 0. Anything positive indicates that this structure being observed is correlated with an increased likelihood of 5-year mortality. A negative value means it's correlated with a decrease in 5-year mortality. So you can see that being an isolate is associated with an increase in 5-year mortality. Being connected to patients who are surviving is correlated to a decrease in 5-year mortality, but being co-present with patients who are dying within 5 years is related to an increase in 5-year mortality. And we see no significant effects of the two-step models. And then even when we add those in, though, we still see fairly consistent results for everything else. Importantly here, so Jim was again talking about adding a lot of controls. There was a question here of whether there would be some latent effects going on within the hospital population and within the way the standard operating procedure of the hospital might work, such that we were missing some way that patients were co-present with one another. So for instance, if Monday afternoons were the day when everybody with stomach cancer was typically given their chemotherapy, you would see that all these patients with a fairly low prognosis cancer would all be faring poorly over time and would all be having mortality within 5 years. And so would that mean, or then you'd see, it would look like that being around patients who died within 5 years increased your likelihood of dying within 5 years. So we tried to adjust for anything within the data that we could, and we also did some sensitivity analyses for some variables we weren't able to include. To put some of this in context, we can look not at the coefficients for the model, but actually look at the predicted survival probabilities. So here we've sort of simulated 3 different patients who come in with varying levels of risk. So not super readable. So for a low risk patient, they're coming in with about a 23% chance of 5-year mortality. The medium risk patient is about 70%, and the high risk patient's about 95% 5-year mortality. When you alter the amount of consistent co-presence each patient has, that number for the low and medium risk patients can alter by 1 to 2% versus just fractions of a percent for the high risk patient. So it shows that if this effect is sort of a causal thing and you could change how much consistent co-presence a patient had, you could change the survival probabilities of patients by 1 to 2%. But for patients who are coming in as fairly high risk, there's not much you could edit in that sense. So the electronic medical records, none of this, we were never able to ask patients who they were around, who they were seeing, who they were interacting with. But this idea of consistent co-presence gave us what we thought was a fairly strong proxy for what a lot of that would be within the ward. So we wanted to then think about some potential mechanisms for what these results might mean. So the no edges indicator is likely something going on like social facilitation or social support, where being around a patient who you're consistently seeing over time, that alone has a beneficial effect on you and can help reduce mortality potentially. Whereas the direct connection counts are something like modeling or informational support, where the health status of the person that you're around is important. So one of the main reasons that chemotherapy is stopped prematurely is if a patient is unable to manage their symptoms, their side effects, and if another patient in the hospital ward is managing their side effects very well and has maybe information, tips, tricks, how to manage that better, that can pass that on, helping you manage your own side effects better, and then helping you stay on chemotherapy longer, which would then have positive effects throughout. It might also be something like a stress response. So if you're seeing somebody who is really doing well over time, it might reduce your own stress about your situation to some extent, which then allows better biological uptake of the chemotherapy and better outcomes potentially. So what did we learn from this? We learned potentially that, one, electronic medical records and hospital administrative data really made this study possible. This is not something that could have feasibly been done by going in, surveying patients, following them up, without some of this potentially preliminary data to show that this effect really might be occurring. It shows that potentially co-presence really does matter in hospitals, who you're around, may have an effect on your health. And that's something to be cognizant of as we change the design of hospital wards. Finally, again, even though I said it would have been really infeasible to do the ethnographic survey study, now that we have this sort of preliminary data, that's probably the type of thing that needs to be done to really go in and check whether this effect is real and causal, and look into some of these mechanisms more thoroughly. So I just want to thank my various collaborators in both my labs, my thesis committee, Mitesh Patel at the Nudge unit where I'm now a postdoc, for some of this. Oh, and I guess I should say, one of the things I'm now working on is trying to combine some of these approaches to both survey patients about their networks and also bring in electronic medical record data from the VA to alleviate some of the limitations of both of those approaches and get the strengths of both. This will be in the slides, but there's a interview I had with Sage Research Methods a couple months ago talking about exactly this, electronic medical records and some of this study. You can click that link if you're interested. And thank you all for your attention.
All right, questions and comments? Jeff, please.
Yeah.
So full disclosure, I'm one of the probably few physicians in the room. My question is how you chose cancer as your patient population, because to me, and again, this may be influenced by being in the UK, end-stage renal disease would be a really interesting patient population to do this in, because patients who are on dialysis normally follow a Monday, Wednesday, Friday, or a Tuesday, Thursday, Saturday schedule, so they almost self-segregate so you can compare two populations and see if you're getting the same results amongst those. I know dialysis is not as widely used in the UK as it is in the United States, but it just made me interested.
No, we pretty much flipped a coin between the two. It was down to those two, and I think it was in looking at some literature. Yeah, and I think the fact that it's not, well, I think we also looked at the sample size, and it was a bigger sample size for chemotherapy. But I think that's definitely something we might look at in the future. Yeah.
Yeah, quick question. Thank you so much. Okay, sounds like it's on. So when it comes to patient mortality, I know you mentioned that the date was recorded, but as people who are on chemotherapy are more subject to the spread of infectious disease and more likely to get an infection and have an adverse effect from that, were you able to look at cause of death and like separate based on that?
No, we just had the date of death. So our outcome was really just all-cause mortality. We didn't want to divide. We didn't have the data to divide into different causes, unfortunately, because I think that would have been something really to look at with a lot of the patients. Yeah.
So I wonder, is there any significant difference between the isolating and the person in your network?
So what's the difference between patients who are isolated versus not isolated? So the difference is whether they have any consistent co-presence. So whether the amount of co-presence they had with at least one other patient was greater than you'd expect by chance. So every patient was in the ward with other people, but only about half the patients were with a patient for extended periods of time over the entire course of their chemotherapy.
Yeah, I know this is your definition, but I think it's any other demographic differences.
Yeah. So whether there is a difference between patients who are isolated versus not. Okay, yeah. So actually the patient populations were fairly similar. They have similar ages, similar, actually no, not similar genders. There were actually more male isolates than there were female isolates. One interesting thing is the people who were isolates did have fewer ward visits during their stay. So it's the way the algorithm was developed, it did need a fair bit of co-presence to really understand what was significant versus what was not. So the patients who just weren't in the ward very much didn't have consistent co-presence. So we did control for a lot of these, for some of these things which were different between patients who were isolates versus not, to also try and make sure that that was not driving the association.
So if there is no difference, could you use this isolated group as a control group to do a quasi experiment?
So in terms of an experiment, we've thought about this a fair bit. So the question is sort of, given if they were similar, could you use isolates versus non-isolates as a control group in an experiment? And I think ethically there would be a bit of issues with doing an experiment to sort of try and maximize the beneficial consistent co-presence. Probably what would make sense is using the fact that if the mechanisms we've hypothesized are some of these social influence things, reduction in stress, if you could sort of do a raises all ships mentality and maybe add in a social worker or social support staff into the chemotherapy ward to try and bring everybody these positive benefits, an experiment like that would probably be a way to test experimentally whether some of this was going on without potentially negatively affecting some patients, which would be the worry about trying to edit chemotherapy schedules. Yeah.
Would it be interesting to look at whether, say, demographic or other kinds of similarities between alters had an effect on this relationship?
So the question is looking at almost like an effect modification of the alters. So yeah, so sort of breaking down the sort of these effects by not just whether they lived versus. We looked, I think, a couple homophily characteristics. So if you were consistently co-present with somebody of your sex versus somebody of opposite sex, and I think we found that there was no significant effects there. But I think we just did it. The data here were, so the UK electronic medical records hospital administrative data didn't include a lot of demographic information. It was pretty much just age and sex. So we did what we could, but that was it, unfortunately.
Mm-hmm. And then my other question was, I assume you're not able to look at the geographic location of the seats, because that would be quite interesting.
Yeah, so that's something the records, so again, records change over time. We actually did find, I think it's in 2012, they actually started incorporating bed level information. Unfortunately, so the reason we ended this study when we did is this chemotherapy ward was shut down, and they opened up a new ward which actually does have individual rooms for patients. So this sort of study wouldn't have. So yeah, so that's sort of, exactly, that's the conclusion, is that might not be the best design for chemotherapy wards.
All right, awesome. Thank you so much.
Okay.